Welcome again, friends. Today I'm going to talk about stomach cancer, a cancer that is pretty common across the world. And to have an idea about the disease burden across the globe, uh, it's enough to say that it is the second most common cancer after lung cancer, which means it is the second cause of cancer mortality after lung cancer. It's mainly disease of the developing countries, China, Southeast Asia, and the entire poorly developed countries. Interesting enough, the incidence is quite high in Japan as well. We want to know that H. pylori plays a major crucial role in the pathology, particularly in distal stomach cancer, and that's where most of the cancers happen in developing countries. Proximal cancer of the stomach, and that includes cancer of the gastroesophageal junction, is also on the rise, but it's mostly in the Western countries. We get often asked about the risk factors for cancer of the stomach, and the known risk factors are, as we said, H. pylori is an important bacteria, the same one that lead to ulceration and this duodenum and the stomach, particularly the type called CAG-A positive, which is a type of a protein that is on the surface of some of H. pylori strains, and it reacts in a complex way with the immune system to initiate chronic inflammatory response in the stomach, which lead to intestinal metaplasia, and that will progress eventually into cancer. Anything that lead to chronic gastritis, and the famous example is pernicious anemia, will lead to chronic gastritis, will lead to cancer. Pernicious anemia is a rare autoimmune disease, lead to the damage of the parietal cell on the mucosa of the stomach, and that lead to achlorhydria and deficiency of vitamin B12, and the achlorhydria will encourage bacterial growth and chronic inflammation and intestinal metaplasia. Other factors that have been blamed are diet and salty diet, that lack of fruit and vegetable, lack of vitamin C and A. Vitamin C is known to work on bacteria to prevent it from changing nitrates in the diet into nitrites. And nitrite is the oncogenic substance in the food. It's particularly available in decayed type of food with lack of hygiene in the developing countries. We see that does happen as a result of poverty. Obesity is an important factor, mostly in proximal stomach cancer and also cancers of the gastroesophageal junction. Smoking is a risk factor with unknown mechanism. Hereditary factors are important. There are families who've inherited faulty genes. Some of them inherit a gene which is called the c-MET proto-oncogene, and that leads to familial cancer of the stomach, and typically happens in a young age and tend to be more aggressive and of the diffuse type, which we will explain in a bit. Alkaline gastroduodenal reflux is a relatively common phenomenon. It's a functional problem for which there is no very effective treatment, often seen in people with reflux and also with gallstone disease and irritable bowel syndrome. The bile salts in the bile are very irritant, and also added to that, the alkaline pH will allow bacterial overgrowth, and that will lead to excessive production of nitrites and hence the carcinogenicity. Sorry, I'm having a bit of technical issue. We need to understand the cancer of the stomach also as a model for carcinogenesis for a variety of other cancers and solid organs. And here we've got a hypothesis that's developed by Correa et al. And the hypothesis says that the problem of the initiation of cancer in the stomach starts with a chronic inflammation, regardless of the cause. And the cause is what we mentioned earlier. That will lead to atrophic gastritis, which eventually lead to hypochlorhydria. So the pH will go up due to lack of production of hydrochloric acid. So these form of inflammations and atrophic gastritis lead to damage of the parietal cells and the mucosa. That will lead to bacterial overgrowth, which will handle the carcinogenic material in the food, the nitrates, and as a result of that, you will get intestinal metaplasia in the stomach. It means that if we are doing gastroscopy for any reason and we find areas on biopsy to have intestinal metaplasia, these patients are at risk of developing gastric cancer and they need to be on long-term survival H. pylori eradication and gastroscopies. Following the intestinal metaplasia, we have a phenomenon which is called intramucosal carcinoma or high-grade dysplasia. Carcinoma in situ is the other name. This means that there are malignant cells, but they have actually not invaded the lamina propria of the mucosa. They haven't gone to the submucosa. And the next stage will be the invasive cancer, where the cancer cells will invade the lamina propria. So adenocarcinoma of the stomach is epithelial cancer, like any other cancer in the gastrointestinal tract from the esophagus down to the colon. And when the pathologists look at it, it has 3 grades: well differentiated, moderate, and poorly differentiated adenocarcinoma. And the prognosis depend on the severity of the differentiation. It's only one of the factors that determine the long-term survival amongst other factors. We stage stomach cancer according to the TNM staging, which stands for tumor, nodes, and metastases. Tumors, we look at the local extent of the tumor, how far it's gone through the wall of the stomach. Are there any lymph node metastases, and are there any distant metastases? There is also another form of staging, which is called the American Joint Cancer Committee. We won't go into the details of that at this stage. There is very important distinction between 2 types of stomach cancer, and that plays a crucial role in the prognosis. And also probably these 2 cancers have 2 different pathways of carcinogenesis. According to Lauren classification, that's the name, Lauren classification, we divide stomach cancer into either intestinal, where there are gland formation, or diffuse, where there are cancer cells without a gland formation. This tend to be more aggressive, more advanced disease by the time of the diagnosis, and more lymphovascular invasion and local submucosal invasion. It's important to know that the diffuse gastric cancer, that's the hereditary type of stomach cancer, could be inherited, as I said, with certain oncogenes, the c-metaproto-oncogene and also the E-cadherin. And the E-cadherin is more known to occur in patients who have microsatellite instability. Now, microsatellite instability is a term used for unstable DNA, where the repair genes in the DNA are faulty and they won't be able to rectify any copying error in the DNA, and that's can lead to a variety of cancer. Also, the diffuse type is more aggressive and have poor prognosis. Now, when we diagnose stomach cancer, the main thing, as we will see in the diagnosis, is an endoscopy. But there is classification of stomach cancer based on the endoscopic appearance. It's not much used, but it is of a bit of theoretical importance. So it's either a polyp form, or it looks like a polyp. We call it polypoid type of cancer. Or it's an ulcer with elevated elevated edges and crater, or it's a flat ulcer, or it's totally flat, where that would happen in the diffuse infiltrative type of stomach cancer. And you will hear often the term linitis plastica. So linitis plastica is caused by the infiltrative, the flat appearing type of stomach cancer. Often it is the diffuse variety according to the Lauren classification. Now, with the TNM staging, I won't go over all the details, but we need to know at least the T stage. Now, it says T1 when it has invaded the lamina propria of the mucosa and gone into submucosa. T2 when it has actually invaded the muscularis propria. T3 when the tumor has invaded the serosa of the stomach. These are the consequential layers of the stomach. And T4 you will find is the cancer that has invaded adjacent structures. And this T classification part of the TNM will be applicable to a variety of cancers with some modifications. Now, clinical presentation, it's very important to have in your mind the possibility of stomach cancer in any of the following situations that we will discuss here. That will be the warning symptoms or the presentation. One of the most common type of presentation you'll see is epigastric pain, and that epigastric pain is associated usually with lack of appetite, early satiety. Satiety means fullness. The patient eats a small portion of their meal and then they feel full and they stop eating and then they get nausea and vomiting. It's important to ask them about the constitutional symptoms, which is applicable to any cancer, as we know that they're weight loss, fatigue, night sweats. Rarely fever. People who present with iron deficiency anemia, it's a red flag for bleed from the gastrointestinal tract, and that bleed could be from anywhere from the gastroesophageal junction down to the rectum. And any patient who present with iron deficiency anemia, they need their, after their iron checked and clinically examined, they will need to have an upper GI endoscopy and lower GI endoscopy for that matter to rule bleeding lesions in the gastrointestinal tract. Now you might ask how about the small intestine if there is a lesion. Just by the way, there is a specific test for the small bowel that is an endoscopic form of investigation by swallowing a camera called PeltCam that gets swallowed and then retrieved and analyzed if there was no reason found in the upper GI tract or the colon. A major presentation of stomach cancer is bleeding, overt bleeding, and that overt bleeding can be in two forms. It's either hematemesis, if there is large volume of blood, or sudden bleed. Blood in the stomach will cause nausea. It's very powerful nausea-causing material and lead to vomiting. The other form is melena, which is usually from trickling blood or some bleeding from the upper GI tract that occurred and happened. Now, melena will happen in any upper GI bleeding from the anywhere, in fact, from the esophagus down to the duodenojejunal flexion. and the reason and melena is passing dark tarry stools. That's the definition for it. And if the patient surpassed dark stools, then you will probably have only two reasons. One of them is that they have melena. The other, they might be having iron supplement. The color of the stool on iron supplement becomes very dark, blackish to green, black greenish type of color rather. Any bleeding below that level usually have fresh elements in it or more red in color, and it's regarded as a lower GI bleed. Now, some patients will present with the classical gastric outlet obstruction, and that happens as a result of tumor in the distal part of the stomach that will block the pylorus, and they come with dilated stomach, hunger and vomiting, unable to tolerate any food material, and when you scan them, you find a big stomach with a lot of residual food in it. I wanted to mention a few things for you. These are classical, historical findings that go along with stomach cancer. They are rare to find these days, but they are described, and I want you to familiarize yourself with them. Now, there's something called system Mary-Joseph nodule. It basically means that there is stomach cancer, or any cancer for that matter. The pancreas can do that as well, where there is a lump, a solid lump in the umbilicus that can be felt easily. Now, this was discovered by one of the Mayo brothers who diagnosed one of his theater nurses with the disease when she complained to him about the lump, and eventually they found she's got stomach cancer, and since then that name was coined to it. The Virchow node is a lymph node in the left supraclavicular region, and that lymph node is a constant anatomic findings. It's the place where the thoracic duct empties or ends at the junction of the brachiocephalic vein and the jugular vein on the left side. And this happened as a result of lymphatic metastases, while Sister Joseph nodule is more likely to be a hematogenous spread. Another phenomenon called the Krukenberg tumor. And the Krukenberg tumor is when stomach cancer settle and metastasize to the ovaries. If you do a scan, you will find bilateral enlarged ovaries, and both of them on laparoscopy, they will have, you will see them clearly. They have a tumor mass on the surface of each ovary. That happened mainly in the diffuse gastric cancer, and we know that because diffuse gastric cancer have the ability to do what we call transcoelomic spread, where cancer cells will swim in the peritoneal cavity and settle on the surface of other organs. The other term is called Blumer shelf, and that's peritoneal metastases in the pelvis, in the pelvic pouch, where it can be felt with rectal examination as a hard mass. In women, it will be in the Douglas pouch. These are rare findings, but just for familiarization and completeness. Now, how do we evaluate? When we go to the patients, we have understood a bit about their pathology, and we go to the patient and we think they might have stomach cancer. How do we evaluate the patients? The same cliche will go. You will have had the history, you did the physical examination, and then you do your routine blood test, which we know the full blood count, the UNEs, the LFTs, the MLAs. And if you are suspecting a tumor, you add tumor marker in the form of CEA, CA19-9, CA125, and sometimes we add chromogranin if we are thinking about neuroendocrine tumor. These patients will need iron studies because they are almost always anemic, not only from iron deficiency as a result of blood loss, but also because of their cancer. Their bone marrow metabolism will slow down, which is a phenomenon that happens across cancers. We need, of course, to see their medical history and assess them for their comorbidities. And it's very important to assess the functional status of the patient, which I will show you in a minute. We need to go over what sort of medication they are on, particularly if they are on anticoagulants. Have they had history of surgery? And we focus mainly on their cardiorespiratory and renal comorbidities because we are assessing the patient assuming that they might be suitable for radical treatment, which involve major surgery. We have to involve a dietitian as early as possible. These patients are invariably malnourished. How do we know? There are a variety of methods that have been tested to see whether any person is malnourished or not. But the two simple tests that have been providing consistent results to us are albumin and lymphocyte count. They both go down in malnourished people. So we will have to involve a dietitian at the commencement of the evaluation and the treatment. So with the functional status of the patient, there is this chart. Just familiarize yourself with it. It's called the ECOG performance status. It stands for the Eastern Cooperative Oncology Group that devised the simple way of labeling the patient's functional status with a number. So if you are fully active, working and doing everything as per normal, that's 0. Anyone who has got any restriction in their physical activity, they will be regarded as 1, even if they are fully ambulatory and they spend all their day or light hours working or doing a variety of things. The stage 2, these are ambulatory people. They can do self-care. They are able to look after themselves, do certain activities, and they are up and about 50% of the waking hours, the daylight hours. If they are 3, I mean they spend more than 50% of their day in bed. If they are 4, these are totally bed confined or wheelchair confined, and they tend to be the highest risk, and they are not suitable for any major intervention. In fact, even if they are stage 3, we will be very careful to offer them any major intervention. But that's a side point. The purpose of this slide is to familiarize yourself with the ECOG performance status, which will be applicable, of course, to any type of cancer and anyone who needs major surgery, whether it's for cancer or otherwise. Now, the gold standard for the diagnosis is the endoscopy, and we take biopsies, and the biopsies prove to be cancer of the stomach. Then staging, how do we do that? We could do the T&M staging, the T part of it at least, with endoscopic ultrasound, which is an ultrasound mounted at the end of the gastroscope, and the operator could appreciate the thickness of invasion. However, it's not widely used because it didn't prove to add much value to the treatment or longevity of the patient. We have to stage them in a systematic way. We do a CT scan of the chest, abdomen, and pelvis, and we do a PET scan, the positron emission tomography, and that's a universal scan that's used for variety of cancer, to see the avidity of the tumor itself, any evidence of regional disease, which is the lymph node metastases, or distal metastases, such as to the liver, the lung, the bones, which are the common sites for metastases, or to the peritoneal cavity. Now, while we're doing that, we do a cardiorespiratory assessment. And typically, the patient will get sent to the high-risk clinic, in particular if they are elderly and have significant comorbidities, to assess their fitness for major curative treatment that include major surgery. Part of the staging system is that staging laparoscopy and washout cytology is one of the tools and part of the staging methods that we use to see the spread of stomach cancer. Staging laparoscopy is designed to look at the peritoneal cavity to rule out peritoneal disease that is not seen on the CT scan. Most patients who have disease in the distal cancer of the stomach, particularly if it's not too advanced on the CT scan, they will have negative results. Those who have positive results are usually people with infiltrative type of cancer, the diffuse variant, and also those who have suspicious lymph node, particularly along the celiac axis and the SMA, which will be shown on the CT scan. Now, people who are not suitable for surgery, who are deemed to be high risk by the high risk clinic, and they are frail, elderly, or have comorbidities that is prohibitive with high risk of dying from the cancer, then we cancel them against surgery. They could be offered chemotherapy, but that has to be taken case by case. If they are suitable for radical treatment, we start with the neoadjuvant treatment. Now, I need to explain the rationale of the neoadjuvant treatment and what neoadjuvant treatment is. Neoadjuvant treatment is giving a patient a few courses of systemic chemotherapy prior to operating on them. And that happened in the cancer of the stomach, cancer of the esophagus, certain stages of cancer of the breast, cancer of the pancreas, and it has been increasingly used in the last 2 decades in these sort of cancers. The rationale is, once you diagnose anyone with cancer, regardless of the primary, unless it's the skin cancer, which is a different pathology, then you assume that the disease is systemic. What does that mean? It means that there are micrometastases or cancer cells. They could be in the liver, they could be in the lung, they could be in the peritoneal cavity, they could be anywhere, in fact, where no scan can see them, because we know the resolution of our scans, the PET scan and the CT scan is about minimal of 5 millimeters. So if there are cancer cells elsewhere, chemotherapy tend to be very effective in eradicating these microgrowths and floating cancer cells. So it treats the systemic disease, and it does few things for us to enhance resectability and longevity of the patients, in addition to treating the microscopic disease. Some people will have relatively advanced disease, and chemotherapy could downstage that disease. Downstaging being that the lymph nodes will respond and the cancer will shrink on CT scan size-wise, and on PET scan it will be less luminant. And that will enhance resectability, increases the number of people that could benefit from surgery. I should mention to you the MAGIC trial, and the story behind the neoadjuvant treatment of stomach cancer. The MAGIC trial is a trial that's done in England that included a large group of patients with cancers of the stomach and cancer of the gastroesophageal junction, and randomized them into the neoadjuvant arm versus the surgery and no chemotherapy. And these patients received 3 cycles of these 3 medications: 5-fluorouracil, epirubicin, and cisplatin. They're very toxic, these, except 5-fluorouracil, which is relatively mild. They have 3 cycles of them, of these medications. The details of that are beyond today's topic. And then we give them a 4 to 6 week break and reassess them. How do we reassess them? Most of the time, particularly if we are worried, we do a CT scan and a PET scan to ensure stability, at least stability of the disease, or even better, improvement or response, and no evidence of new metastases. Now, the patient will go to surgery. What type of surgery we do? There are 2 types of operations that are done for cancer of the stomach. If we have a proximal stomach cancer, the treatment is total gastrectomy plus radical dissection of the lymph nodes. And these lymph nodes along the arteries, the splenic artery, the left gastric artery, the common hepatic artery, and the SMA, the celiac, rather. That involves removal of the entire omentum. And it has been deemed that the minimal acceptable number of lymph nodes that should be retrieved in stomach cancer is 15. We have to harvest at least 15 lymph nodes. Most of them we can't see at the time of the operation, but the more thorough and accurate section, the more the yield of the numbers of the lymph nodes. I won't go to the details of the lymph nodes and their stations, but the lymph nodes around the stomach are divided into 16 stations that you could look up elsewhere. Total gastrectomy is a highly morbid operation. The main risk comes from the anastomosis here, because the anastomosis, or the way that we reconstruct the gastrointestinal tract, we do a Roux-en-Y reconstruction. So the duodenum is cut in here. This is the first part of the duodenum, stapled off. And then we take this and we cut the small bowel in there to bring it up to there and do an anastomosis with the stomach. That could be a stapled or suture. And this form of arrangement is classically called the Roux-en-Y complex. Leakage from the site of the anastomosis is disastrous. Bleeding can be disastrous, and unfortunately these complications do happen. And the cancer mortality from this operation has been reported to be around somewhere between 2 to 5%, depend on the centers, which is very acceptable. Students often ask me, what will happen then to the digestion? Patient will ask, what will happen to the digestion? Will I be able to eat or not? Then I'll try to cover that with a different topic, which will be a post-gastrectomy syndromes in the future. Now, if the cancer is in the distal part of the stomach, then the operation is significantly different. The patient will have what we call a subtotal gastrectomy, which means that about 75% of the stomach get removed, along with the omentum. And when that gets removed, we reconstruct the same way, the Roux-en-Y reconstruction. The functional capacity of the residual stomach is, in this case, is better than having none stomach at all in terms of dietary requirement, meal size, and deficiency of iron and calcium and vitamins. No, the patient had their operation, and once they settle, they will get discharged from the hospital. They get a few weeks rest interval until they recover and heal, and then they get 3 cycles of the same medication according to the MAGIC trial. Now, what's going to happen to the patient in terms of survival and longevity? It's always a stage-dependent problem. Uh, Pathology plays an important role, the histologic type of the, according to the Lauren classification. Also, the effect of the treatment they have. Some people will not be able to tolerate having all their chemotherapy, and that can jeopardize their long-term survival. Lymph node metastases is another definite factor that will shorten people survival and will lead to recurrence. In general, if the patient have curative treatment and being offered all the methods that are available according to what we've discussed here, we see about at least 40% survival rate. It could be better if you choose the fittest and the earliest stages of the patients. How do we follow them up? We follow them up clinically. There are no specific tumor markers, in fact, but we will do a CT scan, and the interval, I do them at 6 months from the operation, and then it will be annual CT scan plus clinical assessment of the patient, and the clinical assessment is related mainly to how they feel, their well-being, their energy and activity, and whether they are losing weight or stable or putting weight on. And if there's any suspicion arise, then we do a CT scan looking for metastases. And these patients, if they survive for a few years and they have limited metastases, a limited recurrence, say in the liver or elsewhere, they could have a more form of palliative chemotherapy that might give them a few more months. Thank you very much.